Okay, so now what we're going to do is we are come to the second part, that is the Valdez ring. Okay, second part is like I'm going to start from where we have stopped. So we'll start with the Valdez ring. Okay, so so what do you see in the Valdez? You must be knowing what Valdez ring is like, because I just mentioned in the last class about the tonsil, right? Okay, let me take the pen out. So about the tonsil, remember I told you what happens what do you see between the palatoglossal and the palatopharyngeal fold? That is, we see the palatine tonsil. So likewise, we have this group of lymphoid tissues which are arranged around the oral cavity in order to protect us from the pathogens, right? So right here, this is the tongue, right? So I said the tongue is divided into anterior 2/3 and posterior 1/3, right? So the posterior 1/3, here we have a collection of lymphoid tissues that we call it as a lingual tonsil. So here is a lingual tonsil that's seen at the below, okay, inferiorly. So here this is inferolaterally, we can say inferior but laterally. So thus we see the palatine tonsil, okay. Then superiorly and laterally, here will be the auditory tube, because this will be the ear here. So we have the auditory tubes like that, auditory tubes, okay. So auditory tubes, you can see they are actually the internal acoustic meatus. They are covered by or protected by a group of lymphoid tissues, and that we call it as a tubal tonsil. So we can say superolaterally we have the tubal tonsil, and then superiorly above we can see the pharyngeal tonsil. So the whole of it looks like a ring, so we call it as the Valdez tonsillar ring. Okay, is that clear? So in children, sometimes this part, the pharyngeal tonsil, they get enlarged, okay, they get inflamed. So what would happen, in that case? So that will block the airway, nasal breathing. That will block the nasal breathing, not airway. In fact, that will block the nasal breathing, and then it makes breathing from the mouth obligatory. Is that clear? Right, this picture I'm gonna skip again. You know way better than I do about the different types of teeth what we have. Yeah, so let's move on to the salivary glands. Again, salivary glands, you know the different types of salivary glands. Yeah, so there are major salivary glands and minor salivary glands. Here you get to see the parotid gland, yeah, one of the major salivary gland, right? Yeah, so here is the duct of the salivary gland, and we discussed in the previous session that where it opens into the vestibule, and I told you exactly where in the vestibule it opens. And then here is the tongue. Right below the tongue, here we have the sublingual gland, and then here is the mandible. This is the mandible which is cut, and right below that we have the submandibular gland. Okay, so you know where it opens as well, because being dentist, it has been very clearly taught to you where are these ducts of these glands opening into. Tongue, I mentioned that it is a solid conicular muscular organ, right? It helps in it has various functions, like of course it helps in deglutition, thermoregulation, mastication, as well as speech. And I very well explained to you the parts of it. Yeah, now if you're gonna look at if I'm gonna draw here, let me go to the previous picture. If I'm gonna draw the tongue, if you're going to draw the sagittal section, so this is how it looks like. This is the tip of the tongue, and then this whole thing, this part, okay. So this is the dorsum of the tongue. This is again divided into anterior 2/3 and posterior 1/3, right? This is where we have the lingual tonsil here, okay. So this we call it as the apex, and this we call it as the base, okay. This part we call it as the base. Now what is the root? The root of the tongue is where the tongue is anchored or fixed. It's like, if you have a tree, this part we call it as the root, is it not? Where the tree is fixed into the ground. So if I have to cut the tree, I have to cut it at this point so that I can remove it. Likewise, I have to cut the roots here, so if I have to remove the tongue out. So this part is called as the root. Base is this end, this part. Is that clear? Okay, so this is called as a ventral surface, which is smooth. That is, if you lift your tongue up and you see the structures beneath it, we have these lingual veins, you can see them, you know, that's where we call it as the ventral part. This is the dorsal part, which is rough. Yeah, here you see this is the dorsal part, which is rough. This is the junction between the anterior 2/3 and the posterior 1/3, which has got a small opening. This opening is a remnant. We call it as a foramen cecum, where actually the thyroid gland had developed at this point. Okay, and these projections, what we see here, they are the lingual tonsil I mentioned. They form the Valdes ring, right? Yeah. So here another picture showing you the dorsal surface, saying that the dorsal surface is not smooth. Instead, it has got small projections, both on the anterior 2/3 and posterior 1/3. Posterior 1/3 we call it as the tonsils, but on the anterior 2/3 we call them as the papillae. Okay, the different papillae, you again know them: fungiform papillae, filiform papillae, circumvallate papillae, and also foliate papillae. So these are the foliate papillae are seen here. So these are the different papillae. Okay, there you go, it's mentioned here. Okay, so these are the different papillae what we see on the dorsum of the tongue. Okay, so yes, again we are going to the different parts of the GIT. So you know where the abdomen is. It's situated right from here. This is the diaphragm, inferior surface of the diaphragm till the pelvic inlet. Okay, so till there we call it as the abdomen. Okay, so it's between the thorax and the pelvis. And for descriptive purpose, to in fact to know the different viscera, the whole of the abdomen is divided into quadrants and planes. Okay, now quadrants and regions. So this is the quadrants. They are basically the quadrants and the regions are divided by means of planes. Okay, so right in the center we call it as the median plane or mid-sagittal plane. Okay, while this is the umbilical region, actually the umbilical region is seen between the vertebrae L3 and L4 in a lean person, not in a person with a big paunch, okay, but the muscles are very lax, no. So this is in a lean person. So yeah, this is the transumbilical plane. Now here you see the whole of the abdomen is divided into 4 quadrants. We call it as the upper quadrant and the lower quadrant, right and the left, upper right, likewise lower right and lower left. So yeah, so that's how we divide them. Now why do we need to know this? As I mentioned, we need to know the viscera which are lying deep to it, to make it very easy for us to know what are the different viscera what are lying deep to it. Now for example, let's come to the right upper quadrant. Here we have the majority of the liver here, okay, and the gallbladder. Then we see the transverse colon, the right half of the transverse colon, and a bit of the upper part of the ascending colon. Okay, what about the right lower quadrant? This is the appendix. Okay, normally it is hiding, the appendix would be hiding behind this is a cecum. It would be hiding behind the cecum. You wouldn't see it like this except for in some cases, but normally it is hiding behind the cecum like that. Okay, so you know the cecum and the appendix is here and the bit of the coils of the small intestine is here. Okay, what about the left upper quadrant? Here there's something, you know, highly vascular structure which is hiding here. That's the spleen, right? And then this is a stomach, correct? And then there's something which is heading towards the spleen. It's both an exocrine and the endocrine organ. That's the pancreas. So this is the reason why we need to know about the different regions and the quadrants. So region is again slightly complicated. Okay, this was more easy, probably it was very easy for you, but this one is a little bit complicated, but let me explain that to you. So if you remember, I said about the clavicle here, right? So this is the clavicle. So this point is the mid-clavicular line, right? I draw a mid-clavicular line here, okay? And okay, here, this is the, okay, let's start with this one. Here's the stomach, right? This is this part, we call it as a pylorus of the stomach. So I'm going to draw a line like that. That would be the transpyloric line, okay? Transpyloric line or a plane. And here, this is tubercle of the ilia. This would be the tubercle of the iliac crest. Okay, so if I'm going to draw a line here, that would be at the tubercle of the iliac crest. It has to be slightly lower than the umbilical region here, this part. So now you can see, okay, let's draw those lines. That's a midclavicular line, and then we have drawn one transpyloric, and then we have the, here is a transtubercular. So now you see the whole of the abdomen, they are divided into smaller regions, not like this. Here you see smaller regions. Now the region around the umbilicus, we call it as the, around this area, umbilical, so umbilical region. Anything above that, we call it as the epi, means above, epigastric region. Below, we call it as the hypogastric region, hypogastric, okay? Now, here on either side, we call it as the inguinal region, right and the left inguinal region. This part would be the right and the left umbilical region, okay? And then here we have the ribs, so we call it as the hypochondriac region, means below the ribs, hypochondriac region. Is that clear? So this is how the anterior abdominal wall is divided into regions and quadrants. So just a simple picture. I know it's simple for me, but it wouldn't be as simple for you. So let's see. Now when we say umbilical region, so here's the umbilical region. Okay, now when I say epigastric region, this is epigastric region. Previously it was very simple. We had divided it to the four quadrants, right? But here these are the regions. So we are being more specific here. So if you look at the epigastric region, that's what we see here. So this is the majority of the stomach is seen in the epigastric region. Okay, so from the pylorus, here is the beginning of the duodenum, the first part of the duodenum. All right, the rest, the second, third, all goes to umbilical region down here. Where is the spleen located? To be more precise, the spleen is located in the left hypochondriac region. While where is the liver located? Liver is seen more in the right hypochondriac. It is seen in the epigastric, and a tiny bit is seen in the left hypochondriac. Okay, so this is why we should know. If you want to know the viscera in precise where exactly it is, we are going to divide them into smaller regions than quadrants. Now the picture just to show you, here is I said this is the first part of duodenum, this will be the second part of duodenum, here's the third part of the duodenum, and then the fourth part of the duodenum. So as I told you, majority of the duodenum is seen in the umbilical region. Okay. What about the pancreas? You see the pancreas. Okay, so you can spleen. Let me start with the spleen. Where is the spleen? Ideally, the spleen should be situated here. This is the location for the spleen. Okay, this is where the spleen is. So here is the hilum or the opening of the spleen. Okay, and you can see the pancreas. The tail of the pancreas is heading towards the hilum of the spleen. So if you're looking at the pancreas, they are seen in all three parts, umbilical region, but majority of them are seen in the epigastric region. And a small bit which is related to the spleen is seen in the left hypochondriac region. Am I clear, guys? So that's the two things, epigastric and the umbilical region. Now here's the small intestine. Okay, so we spoke about the first part of the small intestine, that is the duodenum. Then this is the jejunum. You can see the coils of the jejunum here, and then this ends here. This is the ileum. This part would be the ileum. Here is the jejunum. Okay, so this is the cecum, right? This is the cecum. So this junction between this ileum and the cecum, we call it as the ileocecal junction. And then we have the ascending colon and the transverse colon, and then we have the descending colon. Now let's go back to the small intestine. So basically you can see the small intestine seen mainly in the umbilical region and also the lower region, the pubic or hypogastric region. Okay, and of course it's seen in the lumbar region as well, but mainly seen in the umbilical region and the hypogastric region. Liver and gallbladder, you know where they are seen right now. I already mentioned to you, yeah, epigastric region it will be the gallbladder, or if you're talking about the quadrants, it is the right upper quadrant, right? Spleen, again, I said where it's present. Pancreas, yeah, so pancreas, you just need to know that there are different parts to it. This part is called as the head. This flat part is called as the head. Then a tiny bit, a small area, this area, we call it as the neck. Then the rest of it is the body and the tail. Okay, now if you're going by the body, I'm sure that all of you must have had this chocolate called as the Toblerone chocolate, you know, like that. Remember, this is the chocolate, it looks like, you know. So the same applies here. So what you see here, this would be the anterior border, like that. This border, what you're seeing is the anterior border. The surface, what you're seeing right here is this area. Okay, is that clear? Now the surface, what you can't see, that is the inferior surface, is below here. You can't see that, it's inferior surface. Posterior surface is this. Okay, that is related to all the structures which are lying behind it. Is that clear? So yeah, moving on to the peritoneum. Again, peritoneum, I'm not going to talk much about it. I will just tell you what visceral peritoneum is and what parietal peritoneum is. Now if there is a viscera like that, okay, if this is the abdominal wall, okay, so this is the posterior abdominal wall. Here as the kidney, here are the kidneys, okay, and this is the vertebral column, the body of the vertebrae here, okay. So here we have the great vessels. Now if the peritoneum is going around it like that, you see that, around it like this, around the body wall, okay, we call it as a parietal peritoneum. It is the parietal peritoneum. But if there is a viscera here, imagine the stomach is here, this is a cut section of the stomach, this is the stomach. So what happens to the peritoneum? It will go around the stomach like that, okay, it will go around the stomach like that. If there is another viscera here, for example the liver, so what will it do? It will go around the viscera here, okay, like that. So in this case, we call this as a visceral peritoneum. If the viscera is enclosed by the peritoneum, we call it a visceral peritoneum, while if it is covering the body wall, we call it as a parietal peritoneum, okay. So now there is something called as intraperitoneal organs. So right now I drew the stomach, yeah, and the liver covered by the peritoneum, entirely covered by the peritoneum. So in that case, we call it as the intraperitoneal organs. The same as with the small intestine as well. Now for example, let me draw you the abdominal wall like that. This is the same picture, what you see on the screen, the same thing, okay. So here was the liver, right, here is the stomach, okay, and in here is the pancreas. Remember I said it's like a Toblerone chocolates, like that, okay. And this is a cut section of the transverse colon here, and then we have coils of the small intestine. This is a very schematic picture, okay, coils of the small intestine. Now why can I not get the, okay, so I thought of changing the color of the pen, but it's not. Okay, so anyway, let me go on with the same color. So if you look at the parietal peritoneum, what did I say? It just goes around like that, yeah, it goes around the body wall, right. But if it is visceral peritoneum, it splits to enclose the viscera. Here you can see it's splitting to enclose what viscera is this? This is the liver, right. So this is the liver, okay. Now if I'm going to take it further down, okay, sorry, here, if I'm going to take it for this one, will go around the abdominal wall like that. We call it as a parietal peritoneum. Here you can see it's splitting to enclose the stomach, okay, so it will split to enclose the stomach like that, okay. Now you can see here further it goes down like that, okay, it goes down like that, and then it should come back like this, Okay, it goes back like that, and then it goes over the transverse colon, goes over the pancreas, and goes to the posterior abdominal wall. This one you can see it's going behind the transverse colon, going to the inferior surface of the pancreas, and then going back to the posterior abdominal wall. Then it comes back and encloses all the small coils of the small intestine like that. Okay, so like this, sorry, this way. Now let's look at this. The whole of it is enclosed by the peritoneum. Let's look at this picture here. The whole of it is enclosed by the peritoneum, right? But here, if you look at the pancreas, is it totally covered? No, this part is not covered, right? This part is not covered fully by the peritoneum. Imagine if this whole thing was covered by the peritoneum like that, then we can call it as the intraperitoneal. Now, since the posterior surface is not covered, we call it as a retroperitoneal. Is that clear? So this is why some organs are covered by peritoneum while some are not covered by peritoneum. So these ones which are not covered by peritoneum, we call them as retroperitoneal. So here are the names which are put. We have kidneys, we have pancreas, duodenum, ascending colon, descending colon, rectum. These are few of the organs which are not covered by the peritoneum. Okay. So esophagus, what you need to know about the esophagus is it's one of the important part of the gastrointestinal tube because it is very narrow, okay? And you just need to know that, yeah, the extent of it extends from the pharynx to the stomach, all right? Forget about the different parts of it. What you need to know is its importance, the clinical importance is if you are going to insert an endoscopic tube, the tube is not going to easily pass through your mouth into the stomach because esophagus is not the same everywhere. There are constrictions in the esophagus. So why are these constrictions or where are they seen? So one is seen when you're inserting the tube about 15 centimeters from the incisor teeth. Then that is where the esophagus begins. The pharynx ends and the esophagus begins. That's at that point. The second constriction is where the esophagus is crossed by this arch of aorta, that is about 22 centimeters from the incisor teeth. Next is when it is crossed by the left bronchus, that is around 27 centimeters. Okay, and the last is when it's piercing the diaphragm, that is about 40 centimeters from the incisor teeth. So you just need to know about this. The whole of the esophagus is the diameter of that is not the same. There are constrictions in the esophagus and one has to take care when they are inserting the endoscopic tube. Okay? Yeah, I mentioned about it. Here's just an image just to show you how the foreign bodies can get entrapped in the, this is the first constriction. Where is that? Between the pharynx and the esophagus. Okay? So we call it as a cricopharyngeal sling. All right? And another important thing what you need to know about the esophagus is about its venous drainage. I'm not sure if you heard about the venous drainage of the thorax. It's basically, okay, now let me make it very simple to you. We have the vena cava system. Okay, that means we have the superior vena cava and the inferior vena cava. The other system is the portal system, wherein all the small intestine, all the large intestine, majorly the abdomen, the veins will drain into this portal system. Okay. Now let me show you where the portal system is. Here is the portal system. This is called as a portal vein. So you can see all these veins of the abdomen, they are eventually drained into the liver through a vein called as the portal vein. This is basically for detoxification. And once it is detoxified, they get into the inferior vena cava and into the heart. Okay? But if you look at the rest of the thorax, you can see all of it is either going into the inferior vena cava or into the superior vena cava. So this is called as the vena caval system. Now, there is a confusion at this point of the esophagus. So esophagus, basically, you see it in the cervical region. You see it in the thorax and you see a small bit in the abdomen. Now the part in the thorax, they basically drain into the what? The vena cava system. But the one in the abdomen here, this part, they drain into the portal system. You can see this part has been drained into the portal system. Okay. Now, at this point, that is the lower part of the esophagus here, of the thoracic part and the abdominal part, they have communication with each other. That means there is portocaval anastomosis. Portocaval anastomosis here at this point. It's fine as long as everything is moving smoothly. But what if there is a cirrhosis of the liver, or if there is a block here? So the veins from here, the blood from here cannot go in directly, right? So what happens in that case? They will take the other channel. This part will open up. So let's look at the other picture here. So what's happening here? Let's look at this picture. There's a block, right? So the portal system is blocked. So what will happen? The venous communication between the esophagus, that is the azygous system or the caval system, and the portal system, they open up. Because of that, you will see small dilations here. This is called as esophageal varices. Okay, and eventually this will break, and then the patient will start vomiting blood. Okay, is that clear? Yeah. So this is why you should know about the venous drainage of the esophagus. Stomach, I'm going to skip the situation. You know about where it is seen. Okay, let's move on to the parts of the stomach. Here is the stomach, and this part, we call it as the fundus. This whole thing is the fundus. Okay, so from here to here, we call it as the body, and then we have the pyloric part. This part is the pyloric part, okay? So it has got two orifices, or two ends. The one which is close to the heart, we call it as a cardiac orifice. The other one which is close to the duodenum, this part, we call it as a pyloric orifice, okay? And two curvatures, one which is, like that, we call it as a lesser curvature, and the other one which is greater, we call it as a greater curvature. Two surfaces, this part we call it as the anterior superior surface, which is actually related to anterior abdominal wall and few of the viscera, and then the posterior surface or the posterior inferior surface. Subdivisions we already mentioned. So you don't need to know more about this, all these structures, you don't need to know about it. Here at this point, we call it as the pyloric sphincter, because there are these, I'm not sure if you know about the histology. There are circular muscles in the GIT. So at this point, the circular muscles are condensed and they form an anatomical sphincter. Okay. Now, why do we need to know about few of the relations of the stomach? Is because here, as I told you, anterosuperior or the anterior surface of the stomach is related to the anterior abdominal wall. Okay. Not all, but part of it is related to the anterior abdominal wall. This area is called as the gastric triangle. So the boundaries of this triangle are the lower border of the liver, left costal margin, and also the upper border of the transverse colon. Why is it important? Because if there is a block in the esophagus, a patient cannot eat. Whatever he eats will not go down. So in such cases, the patient will be fed by gastric tube. So if you're going to put the gastric tube at this point, it's not going to be possible, because we have the ribs and other viscera here. Same here, you cannot go in here. But this point, since it is related directly to the anterior abdominal wall, it is easy. There is no viscera covering it, so it is easy to reach the stomach and feed the patient through this place. Okay? Is that clear? So this, we call it as a gastric tube. Moving on to the lymphatic drainage of the stomach. Why is it important? Because you must have heard about the cancer of the stomach, carcinoma of the stomach. So normally, it involves the lymph node. But if you look at the stomach, the lymph nodes are extensively placed around the stomach. So it's very difficult to just target one lymph node. If one of it is, one of it is involved, you can see it's spreading to all these. Okay, so this is why removing all the lymph nodes is very difficult, okay, in carcinoma of the stomach. Now this is gastroscopy. Gastroscopy gastroscopy is visualizing the stomach from its inner aspect. Okay, so you can see here the tube is inserted, and this patient is having an ulcer, pre-pyloric ulcer. So he is having a look at the surgeon is, he can visualize the stomach or the ulcers. Here's a picture of the barium meal. So here you can see the fundus of the stomach very clearly. Okay, so here we see the lesser curvature, greater curvature, body, and the pylorus of the stomach. Okay, now what we need to know about the ulcer is, let's look at, okay, so let's go to this picture here. Going back to one of the pictures, let me see here. Yeah, if you look at this part here, if there is an ulcer at this area, so right behind this is an artery which is running. So imagine if the ulcer is inside the stomach here. So what will happen? It will corrode the muscle wall, and eventually the gastric contents will come out of it. It goes, because it's seen posteriorly, it will go and erode this artery, and eventually there will be bleeding, right? There will be heavy bleeding from that particular artery. So let's move on to the small intestine. By now you know the different parts of the small intestine, and already mentioned about the duodenum, right? So first part, second part, third part, and then we have a fourth part of the duodenum, right? So this is shortest compared to the rest of the duodenum. The whole of this small intestine is about 7 meters, 6 to 7 meters in length. Then we have jejunum, and then followed by the ileum, okay? And as I told you, it ends in the ileocecal junction. I'm not going to go over this again. You know where the duodenum is situated, right? Parts of the duodenum, again, quickly let's go over it. So we have the first part, second part, third part, and the fourth part. You don't need to know the vertebral levels here, okay? So another image just showing you the different parts of the duodenum. Second part is something which is important and you need to know, because you've heard about the major duodenal papillae. Okay, you have heard about the pancreatic duct, yeah? You've heard about the bile duct. So they both merge, okay? They both merge to form the ampulla of the water before it opens as the major duodenal papillae in the second part of the duodenum. So here we have the bile duct, here we have the pancreatic duct. They merge together to form the major ampulla of water, and eventually forms the major duodenal papillae, which is opening in the second part of the duodenum. Not to forget about a small structure, which is the minor duodenal papillae. This is the minor duodenal papillae. So what is it actually? That is accessory pancreatic duct, opening of the accessory pancreatic duct. Okay. Yeah. So duodenojejunal flexure. What is duodenojejunal flexure? If I'm going to draw the duodenum like that, this is the C-shaped duodenum with the first part, second part, third part, and then we have the fourth part going up like that. Now if you look at the fourth part, it becomes continuous as the jejunum. So this bend is called as the duodenojejunal flexure. So normally at this point, if there is any foreign body which is passed in the GIT, if it's passing through the duodenum, it gets caught at this point. And here in this picture, you can see a lot of stuff here, from key, chain, to nail, to the pins, safety pins, yeah? So everything is got caught here. Okay, I mentioned about the ulcer, duodenal ulcer. So what happens? Yeah, there's a nice picture here. Here are the ulcers. So basically, this is what they have done. They have pulled the duodenum. So duodenum is like that, right? They have pulled, this is how the duodenum is, okay? So this is the stomach here. So what they have done is they have pulled it forward in this picture. They have pulled it forward to show the arteries which are lying deep to it. This is what I said about gastroduodenal artery. So if there is an ulcer at this point, so what will it do? So it will corrode the, first of all, the mucosa and then the different layers of the GIT. Then it will see that the gastric juice has been released, and as gastric acids in fact, and that will corrode the artery, okay? So eventually that will cause peritonitis because it goes into the peritoneal cavity. Jejunum and the ileum, well, you can see the whole of this is covered by the mesentery, that is the peritoneum. That's nothing but the visceral peritoneum. and it has got a name called as the mesentery. Okay, so basically the whole of it, the 6-meter thing, except for the duodenum, this part of the duodenum from here to here is not covered by, totally covered by the peritoneum. So the rest all has mesentery. Okay, when there is mesentery, which means that there are chances for the whole of it to coil, okay, to turn around, so that will cause ischemia of the blood vessel. All right, yeah. So large intestine, the parts of the large intestine, cecum, that's the appendix, and I told you that appendix normally is right behind the cecum. We have the ascending colon, then we have the transverse colon, then we have the descending colon, sigmoid colon, and then we have the rectum and the anal canal. All right. Problems of the GIT, appendicitis. This is nothing but the inflammation of the appendix. So basically, you can see, as I told you again, the appendix is retroperitoneal, right behind the cecum. It's seen right behind. So that gets inflamed at times, and that could be severely painful. Okay. Yeah, this is what I was mentioning about what happens to the mesentery. It gets coiled around like that. So because the whole thing is mobile, yeah. So in that case, this is called as volvulus. So where it's basically the arteries, they get obstructed, and that will cause ischemia to the organ. Okay, you heard about CRC, that is a colorectal cancer, right? So basically, you know what cancer is. I'm not going to explain it to you. So this is just a picture vision, image of the abdominal cells which is growing inside. Hernia, I told you what could lead to hernia. So here, if there is an incision which has been put, surgical incision, if it doesn't heal well, the viscera can protrude into this through the anterior abdominal wall, and that we call it as a hernia. Then I mentioned about the superficial inguinal ring. What comes out of it, that's a spermatic cord. Sometimes the viscera can pass from a deeper ring, and then they pass through this ring, superficial. Okay, so in that case, we can call it as the inguinal hernia. There are different types of inguinal hernia, but you don't need to know that again. Femoral hernia is where we have the femoral, ring, and then the viscera pass into that, and we call it as the femoral hernia. Arterial supply of the whole of the gut, I'll keep it very simple. We have the foregut, we have the midgut, and the hindgut. Okay, so let me draw this. This would be just draw a schematic picture of the ascending colon. Okay, so this is the cecum here. Then we have the transverse colon, and then we have the descending colon. Okay, this is just a schematic picture for you. Okay, all right. So now we have the foregut. So when you're talking about the foregut, this will be the stomach like that. Okay, so this is the duodenum. So like you can see, not all of the duodenum, is it not? So where the second part of the duodenum, where the major duodenal papilla is opening, above that is the foregut. Okay, so the blood supply to that will be the celiac trunk. Now the area below that, till if you look at the transverse colon, this is a transverse colon, this is the 2/3, and this is the 1/3 of the transverse colon. Okay, so the 2/3 of the transverse colon, that is from here to here, will be supplied by the superior mesenteric artery, an artery called as superior mesenteric artery. The rest, that is from here, will be supplied by the inferior mesenteric artery. Okay, so rectum and anal canal, basically you need to know about per-rectal examination for the structures what are palpated anterior to it, posterior to it, and on either side. So basically in males, you can palpate the what is this gland called as? This is the prostate gland, right? So you can palpate this prostate gland. Okay, so just to make sure that it is not enlarged. All right, so then now we have something called as a hemorrhoids. We have I'm not going to the depth of this because you just need to know what is internal hemorrhoids and what is external hemorrhoids. External hemorrhoids, basically it is related to the skin. Okay, so which is pain sensitive, so that is why it becomes extremely painful. Okay, while the internal hemorrhoids, they are in the inner aspect, and this is supplied by the autonomic nervous system, so that is why it is pain insensitive. So this is why it is painless. Is that clear? And yeah, I think we are almost done. So this is the anal canal. Again, you don't need to know the depth of this. I'm just gonna skip this. Except for the sphincters, I'll just quickly mention what the sphincters are. Here we have two sphincters which are voluntary and involuntary. Okay, voluntary and involuntary. So voluntary is what we see here. This is the external anal sphincter. You can see this whole of it here on either side of it. That is voluntary. Okay, while you can see these tiny ones here, these are involuntary. These ones what we see here inside are involuntary. Is that clear? So whenever it is involuntary, that means it is supplied by the autonomic nervous system. Okay, all right. So this I already mentioned to you, so I'm gonna skip it. You know what happens to the liver, and what from where is the bile made. Yeah, so if you're looking at the gallbladder is not where the bile is made from, right? Bile is made by the hepatocytes. Gallbladder just stores and concentrates them, and as and when the bile is needed, okay, especially when we eat fatty food, the bile has been released. Okay. Pancreas, as I told you, it is both an exocrine and the endocrine gland, right? So where is the islets of Langerhans present? They are present more towards the tail of the pancreas. This is why they say more concentrated towards the tail of the pancreas. This is why they say when a splenectomy has to be done, removal of the spleen, by, for example, if a person meets with an accident and the ribs, pierce through the spleen, and there will be a lot of blood which has been spilled out, yeah, so they have to remove the spleen. So one has to be careful not to cut the tail of the pancreas, because a lot of these insulin producing cells are seen here, right? So this is why we have to make sure that the tail of the pancreas is retained. Okay, so yeah, we are almost this is the last slide probably. So there's nothing much life-threatening in relation to the GI problems, but eventually if you just leave it like that, it can be systemic problems if we don't treat them. Okay, so thank you guys. If you have any doubts, you can email me. So my email address, I think the faculty who is in charge would post it to you. Anyway, thank you guys, and yes, please stay safe, and yeah, hope to see you someday. See you all someday. Take care. Thank you once again.